Hi everybody, this is Penny, and this is hour 2 of the acid-base learning plan. Here's a little review. This was the last slide from hour 1. It just reviews the normals for ABG values. pH of 7.35 to 7.45 is within normal limits. PO2 or PaO2 of 80 to 100 millimeters of mercury is also within normal limits. A PaCO2 of 35 to 45, and a bicarb of 22 to 26. And as you know, O2 saturation, which is a percentage of hemoglobin that is saturated with oxygen, is normally greater than 95. Okay, the way I'm going to approach this hour is we're going to address metabolic, then respiratory acidosis, and then proceed with metabolic and respiratory alkalosis as Iggy does, your textbook. So to introduce metabolic acidosis, I'd like you to fill in the blank before you peek at the next slide and consider where you feel the pH would be and the bicarbonate. And then with acidosis, as you see, the potassium is elevated. We talked about that in fluid and electrolytes. But I'd like you to reconsider, why would the potassium be elevated? Okay, so with metabolic acidosis, the pH is low, so it is less than 7.35. The PCO2 is generally normal, around 35 to 45, because it's a metabolic problem. But the bicarbonate is low, and that's what is causing the acidosis. There's not enough of that base. As I said before, potassium is elevated in acidosis. That's because there's so many hydrogen ions, or relatively so many hydrogen ions are actually moving into the cell. So the potassium, which is the predominant intracellular cation, has to move out. So serum potassium will go up. This is just a little closer look at some causation behind metabolic acidosis. It could, as we talked about, it could be because the bicarb is below normal, and that's usual. And that's what Iggy calls an actual base deficit acidosis, represented by, she'll put down 3 A's and 2 B's to represent an actual base deficit. Or it could actually be caused by an overproduction of some acids, and that's why there are excessive A's compared to the B's. In general, the O2 level is normal with metabolic acidosis because it's not related to gaseous change, it's related to something metabolic. Okay, with that underlying description being done, I'd like to look at some specific causes of metabolic acidosis. One very primary cause is diabetic ketoacidosis and starvation. Basically, in this situation, the glucose has remained in the extracellular fluid with diabetic ketoacidosis, so the body has to break down fat for energy. And of course, the same with starvation. The body has to break down fat for energy, which results in ketosis, or the result of ketones. And ketones are acids that are byproducts of metabolism. So they're actually pretty strong acids. So it could be a primary cause of metabolic acidosis. Heavy exercise and fever could also result in metabolic acidosis simply from the overproduction of lactic acid. And if you recall, lactic acid is what is produced during anaerobic metabolism. An over-ingestion or an overdose of ethanol or methanol or even aspirin can result in metabolic acidosis simply because they contain a lot of acid. So whether it's intentional poisoning, overdose, or unintentional, those items can cause metabolic acidosis. Okay, 3 more reasons for metabolic acidosis. And when a client is in kidney failure, they're simply not excreting the hydrogen ions and can put them in a metabolic acidosis. Again, it's not respiratory in nature, but it has to do with something else. Now, a couple of instances where there'd actually be a base deficit would be if there were liver, pancreas, or kidney failure. In this situation, there's actually an underproduction of bicarb. So that looks like a base deficit. And also with diarrhea, there's an over-elimination of bicarbonates. So this is something that occurs fairly frequently in our client population that we need to keep an eye on. Signs and symptoms of a client experiencing metabolic acidosis are as follows. As far as the respiratory system, they may be exhibiting Kussmaul respirations, which are deep and rapid respirations that actually serve as a compensatory mechanism to help blow off the extra CO2. So as a client's pH is going down and their hydrogen ion concentration is increasing, their respirations will increase, become rapid and deep. And this is not under voluntary control. As far as the central nervous system goes, client may experience a headache, and there could be a variety of level of consciousness changes from confusion to drowsiness, stupor, even coma. And if you recall, the potassium is elevated in this, and a symptom of elevated potassium is muscle weakness. So you may see that in this client also. So you could see increased muscle flaccidity or weakness. If there are skin changes, they will appear warm, flushed, and dry. The cardiovascular changes are really relevant to the hyperkalemia. So EKG changes will manifest itself in various arrhythmias. Could be bradycardia, could actually start blocking down to where the conduction takes longer to get through the conduction path. So you could see widening QRS, which is representative of ventricular contraction or depolarization. Because of the hyperkalemia, you could also see peaked T waves and maybe even, kind of U waves that join up in there. The peripheral pulses will be thready and weak, and blood pressure is generally low with hyperkalemia. Here are some common diagnoses for a client experiencing metabolic acidosis. Because there are safety concerns, I listed risk for injury first. Ineffective tissue perfusion. We could also add in there decreased cardiac output if there's arrhythmias, of course. It could be altered nutrition related to renal failure, diabetes, or even malnutrition with a starvation. Could be knowledge deficit or non-compliance with a regimen or with a diabetic regimen. So there could be a lot of diagnoses depending on the actual cause of the acidosis. Interventions for the client experiencing metabolic acidosis would be really aimed at treating the cause. So once the cause is identified, then the treatment plan can be implemented. So certainly you'd be monitoring the arterial blood gases. If the client was in diabetic ketoacidosis, you'd be administering insulin. Hydration, if dehydration and diarrhea is a problem, antidiarrheal drugs may help. Bicarbonate really, we used to administer that a lot, but what was happening is people would flip into alkalosis that has a whole different set of problems. And so now it is administered, but only if the bicarb level is emergently low. If it's a renal issue, dialysis can be implemented. And if there is a safety problem with this client, or if they do have any kind of muscle weakness or memory problem, confusion, etc., you'd certainly want to monitor that and document all of that. Monitor for muscle weakness. With hyperkalemia, it can progress pretty quickly to the point where they have trouble actually ambulating from point A to point B, say to the commode. So make sure there are safety mechanisms in place. Assessing their level of consciousness frequently, checking their potassium level and their other electrolytes, and definitely implementing seizure precautions if the potassium is getting up there. Okay, now that we've talked about metabolic acidosis, we're going to address respiratory acidosis. With respiratory acidosis, there will be an increased CO2, which, if you recall, with that carbonic anhydrase formula, ends up with the excess hydrogen ions. So, I'd like you to take a moment and just fill in what range the pH would be and the PCO2. Keeping in mind that generally, because it's a respiratory problem, the bicarbonate level is normal, between 22 and 26. Oxygen level is usually low, and the potassium is still elevated because it's still an acidosis. So why don't you fill in the pH and then the PCO2 and go to the next slide. Okay, so as you can see, with respiratory acidosis, the pH is still low because it's still acidotic, so it's less than 7.35, and the PCO2 is elevated greater than 45. Okay, let's look at the causes of respiratory acidosis. Your book does a nice job in categorizing them into 4 groups, so I thought I'll reflect that here. The first category or reason for respiratory acidosis would be respiratory depression. Very common, we'll see this when a person has received sedation, whether it's just normal amount or over sedation. After a surgery, when they're recovering, they may have decreased respirations because of the anesthetic agent. Poisoning could cause this too. Then your book also says there's some cases in which there are neuron damages in the brain that actually cause a respiratory depression that's physical in nature. And this could be caused, say, by cerebral edema. Even brain tumors and aneurysms could cause respiratory depression. And when respiratory depression occurs, hypoventilation results. And when hypoventilation results, there's just more carbon dioxide retained, and it's not being blown off, and that is why it's a respiratory acidosis. Another reason why hypoventilation can occur is inadequate chest expansion. For instance, if a person has skeletal trauma, and I think an example Iggy used was flail chest, where they actually can't expand their lungs adequately. Respiratory or muscle weakness can go in here too. This includes a lot of, say, like musculoskeletal disorders or muscular dystrophy type disorder, where they actually can't expand their chest wall as effectively as possible. Any kind of external constriction, examples of that might include, say, a body cast or obesity even. In this category, with skeletal trauma, I might actually add pain. Say a person after open heart surgery has a chest wound and is in a lot of pain and does not expand their chest adequately. I also think about people who are on, say, bed rest after a procedure. They have to lay flat, and they're used to sitting up, they may not be expanding their chest adequately and really exhaling. So they may also experience hypoventilation and respiratory acidosis. Okay, 2 other main causes of respiratory acidosis. The third one is airway obstruction. This could be caused by an external element such as, say, neck, throat edema, lymph node swelling, even tumors in the throat and neck lymph area could cause airway obstruction. I think about real bad tonsillitis. That's certainly a lymph tissue. Also, external clothing being too tight may cause an airway obstruction. And then there's internal mechanisms for airway obstruction, such as aspiration. There could be mucus plug or excessive mucus present, or bronchospasms. Those are just some examples. Let's see. And then finally, the 4th reason would be reduced alveolar and capillary diffusion. Basically, poor capillary diffusion leads to poor gas exchange, and CO retention, which is respiratory acidosis, results. Just a few cases. There's a lot of examples. I picked out a few of them. Bad case of pneumonia, COPD, where they are CO2 retainers such as emphysema, ARDS, which is acute respiratory distress syndrome, could all cause that poor gas exchange. Certainly, a significant pulmonary embolism could cause that issue. Drowning, or even sleep apnea, where sleep apnea is kind of a mix between obstruction and poor capillary diffusion. Certainly, I wouldn't give you an example and ask you to tell me which of these four is the cause for respiratory acidosis. I just want you to be able to identify cases that patients are at risk for developing respiratory acidosis, so we can really step in and prevent it. Okay, so what does respiratory acidosis look like? Well, as far as breathing, and that's probably the biggest hallmark symptom, you'd see slow or shallow breathing, known as hypoventilation. They're not excreting or breathing off enough CO2. And of course, their oxygen saturation would also be low because they're not having effective respirations. As far as CNS, it's very much the same. You could see changes in LOC, such as lethargy, confusion, stupor, coma. Neurovascular, because the potassium is still elevated. Muscle weakness, poor reflexes, flaccidity, just like before. As far as skin, similar, warm, flushed, and dry. And guess what? EKG changes. Just about the same, exactly the same actually, because again, we're dealing with hyperkalemia. I threw a couple of diagnoses down here that I thought might be specific for respiratory acidosis. Really, risk for injury could be respiratory or metabolic. And again, if there were cardiac issues with high potassium, cardiac output would be something you'd be monitoring, or at risk for decreased cardiac output. But with respiratory acidosis, I put down ineffective breathing pattern in particular, because you really want to figure out what's going on and why aren't they able to blow off that CO2. Okay, you won't be surprised to hear that to treat respiratory acidosis, the cause really needs to be identified. And once that's identified, it is directly treated to reduce acidosis. So as a nurse, what can you do? Well, you'll be obviously doing a respiratory assessment every 2 hours or as needed, and maybe more frequently than every 2 hours. You'll be listening to the lung sounds, assessing the respiratory rate and depth. Respiratory effort, are they demonstrating retractions? You can add in here O2 saturation as well. And when you do a respiratory assessment, you're also looking at the color of the skin and how their mucous membranes and capillary refill are. The whole oxygenation picture has to be taken into consideration. Drug therapy to reduce mucus and open airways. Common medications used are bronchodilators. Anti-inflammatories, they could be steroidal or non-steroidal. They could be inhaled or given intravenously, or oral, I suppose. And mucolytics to thin out the secretions. Also, if they can tolerate it, if secretions is an issue, you can try to increase the fluid intake to thin out the secretions to help them expectorate. Certainly positioning the client in an optimal position, either mid to high Fowlers, would be good. See in which position your client can expand their chest the most and what level they're most comfortable. As far as pulmonary hygiene or cleansing, you really want to make sure to do aggressive turn, cough, deep breathe, incentive spirometer, all those things with your client regularly to help them blow off that extra CO2. And sometimes chest physiotherapy, many times referred to as chest PT, will be ordered, and that's something generally that respiratory therapy does in the acute care setting. You'll be monitoring the O2 sat probably continuously and applying oxygen if necessary, and it usually is, especially at the beginning. And if it gets bad enough, ventilatory support, using mechanical ventilation may be required. Just a word to remind you that older adults, which is a large percentage of our population, are more prone to acid-base disorders in general, particularly acidosis if they have decreased renal function or if they have chronic pulmonary problems, any kind of COPD where they'd be a retainer. They're also more likely to be taking medications that interfere with acid-base balance and fluid electrolyte balance. So you want to assess, are they on diuretics? Are they taking aspirin and what dose? And how much alcohol they intake. So that would be included on your nursing history. Okay, we're going to talk now a little more briefly than acidosis, but we are going to address alkalosis. In alkalosis, a pH is greater than 4.55, and it can either be in excess of the base, which is represented there by 3 A's and 4 B's, and usually that base is bicarbonate, or it can be caused by an acid deficit, which is represented there by 2 A's and 3 B's. Irregardless of the cause, it is a life-threatening condition, and treatment has to be taken to correct the problem. Okay, this is another fill-in-the-blank slide. I just told you what the pH is with alkalosis, but before you proceed to the next slide, see if you can fill in the rest of these values. Okay, so as you can see, the pH with any alkalosis is greater than 7.45. The PCO2 will be normal initially, so it'll be between 35 and 45. But the bicarbonate is elevated, and that's why it's a metabolic alkalosis. So electrolyte changes, the potassium with any alkalosis is low. And the calcium will also be low because it's actually binding with the potassium. So expect to see both of these levels low. Because what's happening is the hydrogen ions are actually coming out of the cell to try to restore the serum pH, so the potassium moves in. So the serum potassium will be low, as will the serum calcium. However, I want you to keep in mind the hallmark of metabolic alkalosis is an increased bicarbonate level with a normal, then rising PCO2. Okay, so let's take a look at some causes of metabolic alkalosis. And first we'll look at the ones where there's a base excess or too much alkaline or basic solution. The primary reason for that is excessive intake or ingestion of bicarbonate, and generally that is present in antacids. People say maybe at home thinking that they or dealing with really severe heartburn, taking baking soda or Tums or some kind of antacids. And obviously if they're antacids, they are basic in nature, alkaline, and it could lead to pretty severe alkalosis actually. Another reason why you might see a base excess is if they're alkaline substances infused. Examples of that would be the sodium bicarb I talked about before. For instance, if we're trying to correct an acidosis, we may be administering bicarbonate, and then alkalosis will result. Also with blood transfusions, there's a preservative in blood that is very basic. So people who get multiple blood transfusions are at risk for metabolic alkalosis. The acid deficit that could cause metabolic alkalosis, very common, prolonged NG suctioning. Guys, when you have a patient who has a nasogastric tube or who's vomiting quite a bit, the same thing would apply. You really want to keep an eye on their ABGs because they're at risk for developing metabolic alkalosis. Some other reasons, and these are less common, there could be a disease process that increases cortisol or aldosterone levels in the blood, or They could actually be taking medications that cause an acid deficit. An example is a thiazide diuretic. Okay, before I talk about signs and symptoms of metabolic alkalosis, I think I'm going to talk about respiratory alkalosis first, because the signs and symptoms and the treatment is very similar for both of them. So let's talk about the lab values with respiratory alkalosis. I'm going to give you a moment to fill this in and then proceed to the next slide. Okay, so as far as the lab results, you'll find in ABGs for a client in respiratory alkalosis, the pH will still be elevated because it's still alkalosis, right? So it's greater than 7.45. The bicarb, which I don't have listed here, is normal, 22 to 26, because it's a respiratory issue. And because it's respiratory, the PCO2 will be low, so less than 35. As you can see, the potassium and calcium are still low because it's still an alkaline condition. Common causes of respiratory alkalosis: hyperventilation. Just kind of the opposite of respiratory acidosis, right? Acidosis, you had hypoventilation because they were holding in the CO2, which converts to hydrogen ions. In respiratory alkalosis, they're hyperventilating and blowing off CO2, so they have they don't have enough acid in their system, so they're alkaline. So hyperventilation, it could be pain, could be anxiety that's causing hyperventilation. High fevers, hypoxemia, could be a severe infection or sepsis. If they're in heart failure and breathing rapidly, struggling with dyspnea, early respiratory failure, or even a brain tumor, a cerebral tumor that affects the medulla and the respiratory center could cause rapid hyperventilation. Okay, we're going to consider the signs and symptoms of alkalosis as a group. And when you consider alkalosis, I want you to think about signs and symptoms of hypocalcemia and hypokalemia. Keeping that in mind, we look at the CNS changes or signs and symptoms. You could see anxiety, irritability, tetany. Remember tetany from low calcium levels, or seizures. Paresthesia, again, low calcium. Hyperreflexia, muscle cramping or twitching. Skeletal muscle weakness, hypokalemia. I hope this is all coming together for you now and making sense. As far as cardiovascular, you could see increased heart rate. Blood pressure may be normal, but if the hyperkalemia, high potassium, persists, it may drop and probably will. If the potassium is elevated, the person's at risk for dig toxicity, and of course, cardiac arrhythmias. And don't forget the Shavastek and Trousseau sign, positive with hypocalcemia. You could check for that. Okay, so some signs and symptoms of respiratory alkalosis, and this probably won't be too surprising for you, is hyperventilation, which is an increased rate and depth of respirations. There could be several reasons why a person would hyperventilate. Probably the most obvious would be in case of an anxiety, or it could be a response to an anxiety-provoking situation or a change in life situation. It could be a panic attack. Another common reason for hyperventilation is pain. So make sure you're assessing your clients for all of these things. And I'm sure you could think of other reasons too why a person may hyperventilate. Here are just a few potential nursing diagnoses you could employ with your client in alkalosis. Ineffective breathing pattern, of course, that would probably apply to your respiratory alkalosis more than the other. Potential for injury would be appropriate for both. Alteration in comfort, knowledge deficit, and anxiety. Okay, as far as nursing interventions, as a nurse, you'll be monitoring the arterial blood gases very closely and the electrolytes, and then collaboratively treating the underlying cause, whether it's replacing fluid and electrolytes such as potassium chloride or calcium, administering antiemetics for your client who's experiencing nausea and vomiting. As far as GI suctioning, sometimes there's not much you can do about that other than replace the electrolytes, but consider, is this NG tube needed? Could we work toward clamping it and seeing if the client can tolerate not having the tube? Something that you might consider. If it's a respiratory issue where their respirations are increased because of pain or anxiety, certainly medications to address those issues would be appropriate. And also non-pharmacological approaches to address those issues as well. Provide knowledge and support to the client, especially when it's something like, their increased of intake of antacids and how many is appropriate to take in a day, etc. I've known clients who have treated themselves with teaspoons and teaspoons of baking soda, mixing it in water and taking that for their heartburn, which many times ended up being angina. So not only are they coming in with a cardiac condition, but they're in metabolic alkalosis. Certainly providing oxygen therapy if it's appropriate, and again, ventilatory support if needed. And finally, I just want to put a plug in again for our gerontological population that they are at risk for acid-base imbalances. You really have to look at their chronic illnesses and how that might affect their pH level, their kidney function. Keep in mind that their skin is many times either harder to work with, tougher, their veins may be more scarred, and they are typically harder to get IV access in. So keep that in mind when you're working at clients with an electrolyte or acid-base imbalance, that you might want to establish an IV access before an event occurs. I think that concludes hour 2 of this learning plan. And when we get together, I'd like to plan to spend a lot of time working through ABG interpretation, and it will be in small groups with packets. So if you can, I'd like you to go through the study guide that I posted from Connie Lindmeyer. She has a voiceover and a PowerPoint that really talks you through acid-base interpretation and gives several case studies. Before you do that, however, I would encourage you to read the article that I posted on Blackboard called Turning ABGs into Child's Play. It kind of gives you a tic-tac-toe approach to ABG interpretation that many, many students and nurses have found helpful in interpreting ABGs. Please give me a call if you have any questions, and as always, I look forward to seeing you. Goodbye.